So hello friends, today we shall discuss thyroid gland. That is new topic in endocrine, that is thyroid gland. Okay, so we have already discussed the pituitary, parathyroid and the adrenal gland. And unlike these three topics, the importance or the relevance of this topic is that this is one topic we will be reading in multiple specialties, like we will starting from anatomy, physiology, pharmacology, pathology, and then medicine, pediatrics and surgery. So 7 specialties from where you can get questions on a single topic. That is the importance of this topic. So if you study properly, then you will be able to answer many questions from multiple specialties. Fine. And thyroid gland disorders is one area from where you must have seen so many patients in endocrinology. Means if you take endocrine disorders per se, other disorders of pituitary, parathyroid, adrenal, you must not have seen many patients. Okay, you must have seen very few patients. But thyroid disorders and diabetes, these two are the main bread and butter of an endocrinologist. This you must have also seen during your clinical practice. Okay, so you will be able to understand better on this topic because you have seen real patients in your life. So under thyroid gland, I would like to discuss under the following headings. First, we will start with the embryology. After embryology, we will be discussing the important anatomical aspects which will be mostly relevant for the surgeon. Then we will discuss physiology. This is most important from a medical perspective, the physiological aspects of the gland. Then only you will be able to understand the disorders of the gland in a proper fashion. Then we shall discuss the disorders. So along with physiology, I will be discussing the disorders, the clinical features and things like that. And in the disorders, we will be discussing only hypothyroidism as well as hyperthyroidism. Thyroid malignancies will be discussed by the pathologist and the surgeon. Fine. We shall also discuss the treatment. The treatment we will be discussing along with the disorders, and along with some of the physiological aspects, you will be understanding about some of the treatment aspects. So this is how our approach will be on the thyroid gland. So first let us discuss the embryology. Fine. So what do you know about the embryology of the thyroid gland? So we have seen the embryology of pituitary gland as well as the embryology of the adrenal gland. So when we discuss these two glands, I said that adrenal gland has got a cortex and a medulla, and both are developing from different structures. Cortex from the mesoderm and the medulla from the neural crest cells. Similarly, the pituitary gland has got an anterior part and a posterior part. Anterior pituitary was developing from the surface ectoderm, posterior pituitary from the neural ectoderm or neuroectoderm. Similarly, in thyroid also, actually you don't have an anatomical demarcation like the pituitary and the adrenal gland. You don't have cortex and medulla or anterior part, posterior part like that. And the thyroid gland just got a right lobe, left lobe as well as the isthmus. But these three you cannot divide like one is developing from one and then from like that. Division is not there. But from a functional point of view, thyroid gland has got two groups of cells. First group of cells are known as the follicular cells, and the second group of cells are known as the parafollicular cells. Even though I divide like this, it is the follicular cells which is the most abundant cells of the thyroid, and it is a functional unit of the thyroid. It is a follicle, thyroid follicles. Okay, thyroid follicles. In between the thyroid follicles, you have got some cells which are known as just small in number. They are known as parafollicular cells, otherwise known as C cells of the thyroid. So the thyroid hormones, principally T4 and T3, they are actually produced by these follicular cells, whereas parafollicular cells are concerned with production of calcitonin. Calcitonin we discussed along with parathyroid because it was one of the hypocalcemic hormone. It is a hormone which is concerned with reducing the blood calcium level. So we discussed calcitonin along with treatment of hypercalcemia. It is one of the hypocalcemic hormones. Fine. So that's the importance of C cells. So from the embryological point of view, we will see what is the importance. Fine. So first we will start with how thyroid gland's development starts. So this is the floor of the primitive pharynx. Primitive pharynx. In the floor of the primitive pharynx, initially a thickening develops. This is what is known as thyroid enlarge. Okay. And from this thickening, a diverticulum grows downwards. This grows downwards, passes in front of the developing hyoid bone and the laryngeal cartilages. Then at the end of this, it bifurcates into a bilobed structure like this. And then this part, what is this part known as? That is the part which is connecting the floor of the pharynx with the developing thyroid. This is what is known as the thyroglossal duct. Thyroglossal duct or the thyroglossal tract. Finally, what happens? The thyroid gland will develop as a bilobed structure from this, and simultaneously this connection will be lost. In the adult life, the part from where thyroid gland's development started, that will be demarcated by what is known as foramen cecum. Foramen cecum is seen in the tongue at the junction of the anterior 2/3 and posterior 1/3. This is foramen cecum. Fine. That's about foramen cecum. Now, what is the importance of this thyroglossal duct? Thyroglossal duct is important because in the adult life, if there are remnants of the thyroglossal duct, it can develop what is known as thyroglossal cyst. Thyroglossal cyst. They are usually midline structures, usually seen. The most common site of thyroglossal cyst is subhyoid region. Important MCQ from surgery. Most common site of thyroglossal cyst would be subhyoid. Okay, so this will be a cyst-like structure seen in the midline. And the important clinical aspect of thyroglossal cyst is that when you get a midline swelling in the neck, your exercise would be to differentiate this structure from the thyroid swelling. So your differential diagnosis will be whether this midline structure is a thyroglossal cyst or a thyroid swelling. And the main difference will be which one will move with protrusion of the tongue. So thyroglossal cyst will move with protrusion of the tongue, whereas a thyroid swelling will not move with protrusion of the tongue. Both will move with deglutition. These are all surgery points. Okay, important for surgery MCQs. Now, just since I discussed regarding the embryology, I just touched on these topics. Now, from where are these C cells developing? That is another important MCQ. These C cells of the thyroid gland is actually derived from neural crest. They are actually derived from neural crest. They are neural crest derivatives, and they are derived from the fourth pharyngeal pouch. They are derived from the fourth pharyngeal pouch, and they get incorporated into the thyroid gland. The parafollicular cells will be there, and they secrete calcitonin. So that is the importance of embryology. And one more embryological aspect from a clinical point of view is when this tract of this thyroglossal cyst, or that this is known as the path of thyroid migration. So along the pathway of thyroid gland migration, that is from the foramen cecum downward to the final destination, anywhere along the path you can get remnants of thyroid tissue. That is what is known as ectopic thyroid. Ectopic thyroid. And one important MCQ, most common site of ectopic thyroid is in the base of the tongue. Most common site of ectopic thyroid is base of tongue. Base of tongue. The importance of ectopic thyroid is that when you are evaluating a patient for hypothyroidism, you will be seeing by imaging what about the normal thyroid gland, whether it is present, whether it is absent, whether it is hypoplastic, whether it is ectopic. That means, especially when you are evaluating a child with hypothyroidism, you will see for a normal thyroid gland in the normal position. If it is not present in the normal position, you will see whether it is present in ectopic position, including the base of the tongue. In the base of the tongue, the thyroid gland will be known as lingual thyroid. Lingual thyroid. Okay, the important point, clinical point is that if a patient is hypothyroid or if a patient is euthyroid and is having an ectopic thyroid tissue, you should always see that whether normal thyroid is also present, because in most of the cases if ectopic thyroid is present, that may be the only functioning thyroid. So you should not be removing that thyroid, because the patient will develop frank hypothyroidism if you remove the source of thyroxine from that patient. Fine. So these are the two important clinical aspects. One is thyroglossal cyst and second one is ectopic thyroid. Okay. Now, and also we have seen the calcitonin producing C cells developing from the fourth pharyngeal pouch. So we will see the important anatomical aspects of the gland. Basically, we will be seeing the blood supply of thyroid gland. So in the blood supply, we will be seeing the arterial supply and the venous drainage. So we will see, this is the thyroid gland. Okay. So thyroid gland is basically supplied by two sets of arteries. We have superior thyroid artery and we have inferior thyroid artery. We have three sets of veins, two arteries, three veins on either side: superior thyroid vein, middle thyroid vein and inferior thyroid vein. So superior thyroid artery is a branch of external carotid artery. In fact, superior thyroid artery is the first branch of external carotid artery. Inferior thyroid artery is a branch of thyrocervical trunk. Thyrocervical trunk. And thyrocervical trunk is a branch of first part of subclavian artery. First part of subclavian artery. So first part of subclavian artery gives us three branches: vertebral artery, internal thoracic artery and thyrocervical trunk. So thyrocervical trunk gives off this inferior thyroid artery. Fine. Now coming to the venous drainage, superior thyroid vein and middle thyroid vein, both of them drain into internal jugular vein, and inferior thyroid artery that drains into brachiocephalic vein. Brachiocephalic vein, the base of the brachiocephalic trunk. Okay, and in less than 5% patients, you can have a third artery which is supplying the isthmus of the gland. That artery is known as arteria thyroidea ema artery. This is supplying the isthmus of the gland in less than 5% of the patients, and this is a branch of arch of aorta, or it can also be a branch of brachiocephalic trunk. Brachiocephalic trunk. Okay, so this is about the arterial supply. We have two arteries mainly. In less than 5%, you can have a third artery supplying the isthmus of the gland. You have three veins: superior, middle and inferior, and how they are draining to. This is important from, actually this is important from surgeon's point of view. And also along with this, you should study two nerves which are importantly related to thyroid gland, two nerves. The first nerve is external laryngeal nerve, which is a branch of superior laryngeal nerve, external laryngeal nerve. Another nerve which is very important is recurrent laryngeal nerve, as well as external laryngeal nerve. The external laryngeal nerve supplies cricothyroid, which is a tensor of the vocal cord, cricothyroid. Whereas recurrent laryngeal nerve supplies all muscles of larynx except cricothyroid, That is why when you get bilateral recurrent laryngeal palsy, we can have respiratory obstruction. Respiratory obstruction can be seen when there is bilateral recurrent laryngeal nerve palsy. Fine. Now, this external laryngeal nerve accompanies superior thyroid artery, and the recurrent laryngeal nerve accompanies the inferior thyroid artery. Okay, so during surgery, the surgeon will be very closely looking for this recurrent laryngeal nerve and the external laryngeal nerve, because their aim is to safeguard this nerve during the thyroid surgery. So for that, when they are ligating the artery, that is, they have to ligate superior thyroid artery as well as inferior thyroid artery during the surgery, right? So they will be ligating it close to the gland. In the superior pole, they will be ligating the artery close to the thyroid gland. Inferior thyroid artery also will be ligated closer to the gland because of two reasons. One is to avoid injuring the recurrent laryngeal nerve. Second one is very, very important from a medical point of view. Inferior thyroid artery also supplies parathyroid gland. inferior thyroid artery supplies parathyroid gland. Fine. So, if you are actually, the inferior thyroid artery is supplying the parathyroid gland mainly from the trunk of the artery. So, if you are actually ligating the artery in the proximal aspect, you are more likely to cause damage to the artery supplying the parathyroid gland. So, that should be avoided. So, it will be closely ligated, close to the gland. Fine. So, this is very important from a medical point of view, because when we prepare patients for surgery, thyroid patients for surgery, especially hyperthyroid patient, and post surgery, our main concern is hypoparathyroidism. So, one of the reasons for hypoparathyroidism post surgery is, one reason is vascular damage to the parathyroid gland, that is they are injuring this artery which is supplying the parathyroid gland. Artery means they are actually cutting the artery more proximally so that the parathyroid is actually compromised. Second reason is they are actually removing the parathyroid along with the thyroid gland inadvertently. That is also another reason. Fine. So, this is important from surgery, and its parathyroid aspect is important from an endocrine point of view. Fine. So, after embryology and anatomy, we shall move on to discuss the physiological aspects, that is proper medicine. So, physiology of thyroid gland. Under physiology, we will be starting with the synthesis of thyroid hormone, how thyroid hormone synthesis is happening in our body. So, thyroid hormone synthesis. For synthesis of thyroid hormone, the most important substance which you need is iodine. Okay. And what is the source of iodine? Iodine we get from the diet. So, what is the recommended daily allowance of iodine? For adults, it is 150 microgram per day. The WHO recommended daily allowance of iodine is 150 microgram per day. For this is for adults. But during pregnancy and lactation, because the fetus and the child also needs iodine, the requirement increases to around 250 microgram per day. 250 microgram per day during pregnancy and lactation. Very important, pregnancy and lactation. If you take children, two more values you have to study. One is 90 and 120. 90 microgram per day and 120 microgram per day. This is up to 6 years. This is 6 to 12 years. So, by adults, it is more than 12 years. So, 90, 120, 150 and 250 are the four values which are the recommended daily allowance of iodine that you need. Fine. So, the iodine which you get from the diet, what happens to iodine? That is what you are going to see. Before that, let me show you what is the functional unit of a thyroid gland. That is a thyroid follicle. So, if you see a thyroid follicle looks like this. This is a thyroid follicle. So, the thyroid follicles are lined by what type of cells? The cell type depends upon the activity of the gland. If the gland is active, it is lined by columnar cells, and if the gland is silent or the gland is not actively involved in hormone synthesis, the cells will be cuboidal. Okay, and this follicle will be actually surrounded by blood vessels. So, let us see an enlarged view of this one follicle cells with the blood vessel. We will see an enlarged view. I will draw it here. This is a thyroid follicle. And here you have the blood vessel. Okay. Now, let us start with synthesizing thyroid hormone. So, for that you need iodine, and the iodine which is present in the diet is present in the reduced form, that is in iodide. And this iodine has to be first transported into the thyroid follicular cells. For this transport, in the thyroid base, this is the basolateral membrane, this is the apical membrane. Yes, this is the basolateral surface, This is the apical surface of thyroid gland. So in the basolateral membrane, you have one important channel which is actually helping for this iodide transport, that is known as sodium iodine symporter, NIS, sodium iodine symporter. So it transports sodium along with iodine. It is actually a symport, sodium iodine symporter. Very important points regarding sodium iodine symporter is that sodium iodine symporter or NIS, it is present in thyroid. Apart from thyroid, what are the other sites where you can get sodium iodine symporter? First important one is it is present in the breast. It is mainly present in lactating breast. Also, it is present in the placenta. It is also present in salivary gland. So, what is the physiological significance of NIS present in breast and placenta? Thyroid gland we have seen, that is for iodine trapping. This first step in the iodine transport is what is known as iodide trapping or iodine uptake. Iodine uptake or iodine trapping. That's the first step in thyroid hormone synthesis. So for that you need NIS in the thyroid gland. So what is the purpose in the breast and in the placenta? So in the breast, the lactating breast require NIS because the baby also needs iodine for thyroid hormone synthesis. So that has to be transported across the breast milk, right? So the lactating breast also needs NIS channel. Placenta also requires this channel because from the maternal blood, the placenta, the iodine reaches the fetus. The fetus also needs iodine for fetal synthesis of thyroid hormones. So that is transported through the placenta with the help of NIS channel. It is also present in salivary gland. The function is not known, but it is also present in salivary gland. It is also present in several other sites, but this much is enough for you. Fine. Now, the iodine which has reached here, what is the next step? What happens to this iodine? The iodine will be transported across this apical membrane to what will be present here? What will be present here in the thyroid follicles? Colloid. So the follicles are actually filled with colloid. So here you have the colloid. Okay. Now, in the apical membrane, you have some important enzymes present in the apical membrane. These important enzymes will be catalyzing some important steps. We will see now. The iodine will be transported across this apical membrane with the help of another transporter which is present in the apical membrane. The name of the transporter is, this also transport chloride. Chloride will be transported in and iodine will be transported out. So it is a chloride iodide antiport. It's an antiport. Previously we had seen a symport, sodium iodine symport. It's an antiport. The another name for this antiport channel is pendrin. So chloride iodide antiport is also known as pendrin. The importance of pendrin is that a mutation of this pendrin channel results in a disorder known as Pendred syndrome. So what is Pendred syndrome? Remember, this chloride iodide antiport is present in the thyroid gland and also it is present in the inner ear cochlea. So cochlea as well as thyroid gland has got this channel, chloride iodide antiport. So the patient with a defect of this pendrin channel or the pendrin protein will have defect in thyroid gland as well as defect in the inner ear. So what is the manifestation in the inner ear? The patient will have sensory neural hearing loss. In the thyroid gland, the patient will have goiter because of defect in the organification. The next steps in thyroid hormone synthesis will be oxidation followed by organification. So this organification of iodine will be defective in Pendred syndrome. You can understand because only if iodine is transported across the apical membrane, further steps can be carried out. So manifestations of Pendred syndrome will be the patient will have sensory neural hearing loss with organification defects of thyroid gland resulting in goiter. Fine. And Pendred syndrome, the gene is present in chromosome number 7. Chromosome number 7. And your ENT teacher will teach you that in the cochlea, in Pendred syndrome, if you do an imaging, you will get a classical manifestation known as Mondini's dysplasia. Mondini's dysplasia is one of the imaging finding. If you take a CT of the inner ear, you will see what is known as Mondini's dysplasia. Mondini's dysplasia is nothing but normally cochlea has got 2.5 turns, whereas in Mondini's dysplasia, you will have a cochlea with 1.5 turns. So that is Mondini's dysplasia. That is seen in Pendred syndrome. That is not seen in Pendred syndrome alone, it is in other disorders also, but in Pendred syndrome, if you are asked what is the imaging finding in the inner ear, it is Mondini's dysplasia. Right. Now, coming to the next step. So, the second step was transport of the iodine across the apical membrane with the help of the antipode channel. Next step. So, iodine has reached this apical membrane and this iodine will be oxidized to iodine. So, this was iodide. This reduced form will be oxidized to iodine. So, for this oxidation, what is required? This oxidation is carried out with the help of H2O2. H2O2. This H2O2 is actually provided by dual oxidase, deox. So, deox will give this H2O2. Dual oxidase will give this H2O2, and this reaction is catalyzed by very important enzyme that is known as TPO. That is thyroid peroxidase. Thyroid peroxidase. So, thyroid peroxidase will catalyze this oxidation of iodide to iodine. Thyroid peroxidase. So, iodine is oxidized. Oxidized form of iodine is there. Now, what is the next step? So, this is the third step. The next step in the thyroid hormone synthesis will be what is known as organification. Organification. So, what is organification? This iodine will be added to tyrosine residues of thyroglobulin. So, we have thyroglobulin which are synthesized from the endoplasmic reticulum and that will be processed in the Golgi apparatus, and this thyroglobulin will be secreted into the colloid. And the thyroglobulin molecules has got tyrosine residues. So, in organification step, iodine will be added to tyrosine residues of thyroglobulin. So, this result in formation of, we have thyroglobulin. The tyrosine residues will be added to iodine. So, that results in the formation of monoiodotyrosine. When one molecule of iodine is added, we get monoiodotyrosine. When two molecules are added, you get diiodotyrosine. So, you have monoiodotyrosine and diiodotyrosine on organification of thyroglobulin with iodine. That is the next step. That is step number 4. Step number 4 was organification, resulting in the formation of monoiodotyrosine and diiodotyrosine. This step is also catalyzed by TPO. Now, this monoiodotyrosine, two molecules of diiodotyrosine will combine together, resulting in the formation of tetraiodothyronine or thyroxine, that is T4. One molecule of MIT combines with one molecule of DIT forming T3 or triiodothyronine. In small percentage, when one molecule of DIT combines with one molecule of MIT, there is a formation of another molecule known as reverse T3. Reverse T3. This is formed in very less proportions. The main thyroid hormone synthesized in the thyroid gland is T4. T4 followed by T3. And reverse T3 is formed in very less proportions. So, this step is what is known as coupling. coupling, that is combination of DIT with MIT resulting in the formation of T4 and MIT with DIT resulting in the formation of T3 and DIT with MIT forming reverse T3. This step is what is known as coupling reaction, and this is also catalyzed by TPO. The fifth step we are studying is coupling reaction, which is catalyzed by TPO. So once this T4 and T3 are formed, they are actually still attached to this thyroglobulin molecules. Okay, so this will be attached to thyroglobulin molecules as T3, T4. That is, they are still attached to thyroglobulin molecules. Okay, so that is still complex with this. Once the body needs thyroid hormones, this will be taken up into the thyroid follicle cells. I'll just erase this. Okay, I'll just enlarge this a bit. Okay, so this is a follicle cells. I'm drawing like this just to make a room for it. So this thyroglobulin molecules will be thyroglobulin molecule with the T4, T3, MIT, DIT on it. This will be actually endocytosed back into the follicle cells when the body needs it. Endocytosed, and they will be actually, this endocytosed thing will be actually fused with lysosomes, and inside the lysosomes what you have, the proteases. So the proteolysis will happen, and once proteolysis is happening, they release T3, T4, MIT, T3, T4, MIT and DIT. That means this thyroglobulin molecule complexed with all these things will be endocytosed. This endocytosed thing will be actually mixed with or fused with these lysosomes. Inside lysosomes you have the proteolytic enzymes. They will be cleaving these T4, T3, MIT and DIT from thyroglobulin and releasing, thyroglobulin will be released and they will actually go back to the colloid, be stored in the colloid. This T3, T4, what will happen to T3 and T4? So here we have drawn a blood vessels. So this T3 and T4 will go to the bloodstream, right? And this MIT and DIT, they will actually be acted upon by another enzyme which is known as dehalogenase. Dehalogenase enzyme, otherwise known as iodotyrosin deiodinase. Iodotyrosin deiodinase, iodotyronin deiodinase enzyme, and releasing iodine, and this iodine will actually go back to this stream, go back to this pool. That means there is recycling of iodine with the help of this dehalogenase enzyme. So from the monoiodotyrosin and diiodotyrosin, iodine is released. This will be taken up by the cells just like the previous iodine uptake. From the iodine uptake, it will be going back to the colloid and the process will be continuing. That is, there is recycling of the iodine from MIT as well as DIT molecules. Okay, so this is the importance of thyroid hormone synthetic pathways, and this pathway is very important to understand the action of antithyroid drugs. Antithyroid drugs. Here you have mainly three groups of antithyroid drugs to study. The first group will be blocking the sodium iodine symporter. So one clinical importance of sodium iodine symporter we have seen, that is sodium iodine symporter is also present in salivary glands, lactating breast and placenta. The physiological significance we have seen. So what are the clinical significance of this NIS transporter? We will see. NIS, sodium iodine symporter. It has got one pharmacological significance and also it has got one diagnostic significance. In the investigation point of view, this is important. From pharmac point of view, it is important because this is actually blocked by, this NIS is blocked by thiocyanate and perchlorate. Thiocyanate and perchlorate will actually compete with iodine for the sodium iodine symporter. So practically they are blocking this transporter, blocking the iodine transport into the thyroid follicular cells. So these are actually antithyroid drugs which were previously used. Antithyroid drugs which are previously used, that is thiocyanate and perchlorate, but they are not used nowadays because of toxicity. For example, perchlorate is associated with aplastic anemia and thiocyanate is associated with psychosis. So we have better drugs with better side effect profile that we'll be studying. So that is why we are not using these two drugs now. Right. From a diagnostic point of view, we have another important point, that is iodine will be taken up by these thyroid follicular cells. This important aspect is used in the radioactive scanning of the thyroid gland. Radioactive scanning of the thyroid gland. That means you are using the normal iodine which we mentioned here. The normal iodine, the dietary form of iodine is iodine 127, which is not radioactive. We have two radioisotopes of iodine, that is iodine 123 and iodine 131. They are radioisotopes. Iodine 123 actually emits gamma rays, whereas iodine 131 emits gamma as well as beta rays. So for diagnostic imaging, you need this gamma rays, which is actually produced by iodine 123. Iodine 131, in addition to gamma, they produce beta also. Beta is actually a damaging radiation. Okay, so for diagnostic purpose, actually we are using iodine 123 because of the fact that it emits only gamma radiation. Okay, why we are able to use these two isotopes for scanning can be understood from this, because if you are giving iodine 123 here, this will be taken up by this sodium iodine importer, and it will be taken up into the thyroid follicular cells, and they will undergo all these steps and will be concentrated inside the thyroid gland. So if you are using this isotope of radioiodine, you will be able to image this gland and see if these processes are happening properly. That means this radioiodine scan is mostly done when the patient is having hyperthyroidism. And my aim as a clinician will be to differentiate whether the hyperthyroidism symptoms the patient is having is due to a hyperfunctioning of the thyroid gland or because of another condition that is known as thyroiditis. So when a hyperthyroid patient comes to me, my aim is to, hyperthyroid means a patient with thyrotoxic symptoms in the form of hyperhidrosis symptoms, palpitation, tremor, all those symptoms, along with that the patient is having biochemically the patient is hyperthyroid, that we will see in details. So my aim is to differentiate whether the gland is hyperfunctioning. That is what is known as hyperthyroidism. If the thyroid gland is hyperfunctioning, it is known as hyperthyroidism, or it is just because of the inflammation of the gland resulting in the release of hormone. That is what is known as thyroiditis. Thyroiditis means there is inflammation of the gland, so the preformed hormones inside this colloid will all be released into the bloodstream and resulting in symptoms of hyperthyroidism. So in that scenario, this gland is not involved in increased production now. What has been formed inside was released. Okay, the preformed hormones are released. So the gland is not hyperfunctioning. Hyperfunctioning means the gland is now not engaged in active hormone synthesis. Whereas a patient with hyperthyroidism, the most common cause is Graves' disease. Graves' disease is hyperfunctioning of the gland because of an autoimmune pathology. Right. So in Graves' disease, the gland is hyperfunctioning. There is more production of hormones, so that all these steps will be accelerated. So that can be found out by an iodine scan. For example, if you give a radioisotope and look for what is the percentage of uptake by the gland, you will be able to get an idea how much the gland is hyperfunctioning. So the main diagnostic utility is to differentiate between Graves' disease and thyroiditis. Graves' disease and thyroiditis. So for diagnostic imaging, we can use these radioisotopes because of this physiology. That is, this iodine isotope will be transported by the sodium iodine importer. Okay, details of radioiodine scan we will study later on. Fine. Now, another importance of this one was pharmacology that we have seen, as well as the diagnostic importance we have seen. And one more radioisotope which we can use is technetium pertecnate. Technetium 99 pertecnate, and this pertecnate will also be taken up by the sodium iodine importer. Okay, so along with thiocyanate perchlorate is technetium pertecnate. The pertecnate will also be taken up by the thyroid gland through the sodium iodide importer. So pertechnetate is complex with technetium isotope, radioisotope. So that is also taken up by the gland, but main difference is that it is just taken up by the gland. Iodine will be taken up by the gland and iodine will be used for the hormone synthesis. But this technetium pertechnetate will be taken up by the gland, but it is not used for hormone synthesis. So any defect in the hormone synthesis you will not be able to find out by this scan. You will be able to find out whether the gland is able to take up this hormone. That is also seen in hyperfunctioning of the gland. That you must not have understood this. That is, the main difference is that if you are using an iodine radioisotope, it will be used, the iodine will be taken up by the gland. This uptake is there. Along with that, it will be going through all the steps of thyroid hormone synthesis. In children with congenital hypothyroidism, one of the cause is dyshormonogenesis. That is, there is a defect in one of the steps in the thyroid hormone synthesis. For example, they can have a defect in the TPO. So thyroid hormone synthesis is not happening properly. So if you want to find out if there is a defect in one of the steps in the thyroid hormone synthesis apart from the uptake, then you will not be able to find out with the technetium scan, because it is just taken up by the gland. It is not used up for these steps in the hormone synthesis. But if it is iodine, it will be taken up and also used for this synthetic pathway. So you will be able to find out if there is any problem with dyshormonogenesis. That is important for children mainly. Okay. Now, first group of antithyroid drugs we are discussing were this group of drugs which is blocking the sodium iodide importer, thiocyanate and perchlorate. Second group of drugs which are most important and the most commonly used class of drug, they are known as thionamides. These thionamides are actually blocking this TPO. Okay, the thionamide classes of drugs, thionamides, they are the most commonly used drugs. The name also you know. One is propyl thiouracil and second one is methimazole. So propyl thiouracil and methimazole, they are the thionamides which are used as antithyroid drugs. They are blocking the TPO enzyme. The third group of drugs, or third drug which is mainly used is the iodine itself. That means, what is the relation of iodine with thyroid hormone synthesis? What is the relation? Always remember, that is very important to understand the importance of iodine with regard to thyroid hormone synthesis. So remember, if you give more of iodine, so iodine is needed for thyroid hormone synthesis, everybody knows that. But if you give more of iodine, the body will actually suppress synthesis of thyroid hormone. So excess of iodine will actually suppress the hormone synthesis. Mainly the organification steps will be suppressed. That is what is known as Wolff-Chaikoff effect. That means, if you give more of iodine, the thyroid gland is trying to protect itself by decreasing the thyroid hormone synthesis, mainly at the organification level. Right? That is Wolff-Chaikoff effect. But if a thyroid gland is normal, this gland will be able to overcome from the suppressive effect in a few days' time. And that is known as recovery from this Wolff-Chaikoff effect or escape from Wolff-Chaikoff effect. But if a patient is having some autoimmune thyroid disorder like Hashimoto's thyroiditis, the gland will not be able to recover from this Wolff-Chaikoff effect and the patient will develop hypothyroidism. So that is regarding Wolff-Chaikoff effect. Okay, and so excess iodine can produce hypothyroidism. Similarly, excess iodine in a patient with iodine deficiency. So if the patient is having iodine deficiency, what will happen to the gland? Just like iron deficiency, so iron is absorbed by these transporters in the GIT. So when there is iron deficiency, these transporters will be overactive, will be trying to absorb more of iron. Similar to that, the patient is having iodine deficiency, so our body will be trying to the thyroid will be trying to maximally absorb the iodine from the bloodstream. maximally take the iodine from the bloodstream for the iodine synthesis, the thyroid hormone synthesis. So, similarly, in a patient with iodine deficiency, the NIS function will be high. That is, sodium iodine symbiotase function will be high. So, these patients can develop a form of hyperthyroidism. So, a patient with iodine deficiency, and mostly those patients will be having goiter also, a nodular goiter. So, a patient with iodine deficiency and nodular goiter, if you are giving very high doses of iodine, they can develop hyperthyroidism, and this phenomena is what is known as Jod-Basido phenomena. Jod-Basido phenomena. That is seen in patients with iodine deficiency goiters. If you give more of iodine, the patient can develop hyperthyroidism. That's known as Jod-Basido phenomena. What I was discussing is not these. I was discussing iodine as an antithyroid drug. So, if you give very high dose of iodine, can actually suppress the thyroid hormone synthesis. So, very high doses of iodine will, I am talking about very high doses that will suppress the thyroid hormone synthesis. It is actually the thyroid hormone synthesis suppressed at multiple levels actually. Actually, the main step which is blocked will be this part, that is, the release of thyroid hormones into the bloodstream will be blocked by iodine. Release will be blocked, mainly the release will be blocked. That is why in previous books you will find that iodine will produce what is known as thyroid constipation. Means it cannot release the hormones in the bloodstream. So, it produces constipation for the hormones. So, it cannot release the hormones into circulation. The release will be mainly blocked. Fine. So, the importance of iodine as an antithyroid drug. What is the importance? You must have used in surgery. That is, mainly when a patient with hyperthyroidism is prepared for surgery, thyroidectomy, you will give this iodine, because the advantages are many. One advantage, the most important advantage of iodine as an antithyroid drug is that it is the fastest acting antithyroid drug. It is the fastest acting antithyroid drug. Along with that, it also has some additional advantages, like it can reduce the size of the thyroid gland. It can reduce size thyroid gland, so the surgeon will be able to better actually safeguard these nerves. A large gland is always at risk of damage to the nerves during surgery. If the surgeon is able to reduce the size of the thyroid gland with the drug, then it will be helpful for him, right? And also it reduces angiogenesis. So that means the blood loss during surgery can be reduced. So, these are the advantages of iodine as an antithyroid drug. It is used mainly for surgery, and also it is used during thyroid storm. It is not used for routine practices for management of Graves' disease. For that we use this group of drug, that is thionamides. Okay, so from this you must have got an idea regarding the thyroid hormone synthesis and what is the importance of each of these steps. And also one more important point I will mention from this itself, what is the importance of TPO and TG in diagnostic practice. TPO is thyroid peroxidase and thyroglobulin. So, in hypothyroidism we will be studying what is known as autoimmune hypothyroidism. So, what is autoimmune hypothyroidism? We will be studying in hypothyroidism, autoimmune. It is otherwise known as Hashimoto's thyroiditis. Hashimoto's thyroiditis or Hashimoto's thyroid disorders. Okay. So, in this group of autoimmune disorder, the antibodies are produced against mainly 3 antigenic targets. The 3 antigenic targets against which antibodies are produced are, one is TPO, second one is thyroglobulin, and third one is TSH receptor. TPO stands for thyroid peroxidase, thyroglobulin, and TSH receptor, in which TPO and TG antibodies, that is anti-TG antibodies and anti-TPO antibodies, these are seen in almost all patients with autoimmune hypothyroidism. These 2 antibodies are seen in almost 100% patients with autoimmune hypothyroidism. That means this can be used as a marker of autoimmunity in thyroid disorders. That is significance. Fine. what is the significance of TSH receptor antibody? That is not seen in all, it is seen around 20% patients with hypothyroidism. This is more important for hyperthyroidism. That means you have anti-TSH receptor antibody. And there are two types of anti-TSH receptor antibody. That means you have an antibody which is actually going and binding to this TSH receptor. Okay. This antibody can do two things. Two things can be done. So first, it can be either a stimulating antibody. That means it can go and bind to the receptor and stimulate this receptor. Then it is known as stimulating antibody. That is what is seen in hyperthyroidism. Specifically speaking, this is what is seen in Graves' disease. So in Graves' disease, you have TSH receptor stimulating antibody. But in hypothyroidism, you have inhibiting antibody. This will go and bind and inhibit the production of thyroid hormones. That is inhibiting antibodies. That is seen in Hashimoto's disease. Okay, so this receptor antibodies are more commonly seen in Graves' disease. Okay, that's the significance of TPO and TG, anti-TG, anti-TPO and anti-TSH receptor antibodies. So what is the fate of the thyroid hormones once it is secreted in the bloodstream? That means we have the thyroid hormones T3 and T4 in the bloodstream. So what happens to them? Okay, so first we should know what are the differences between T3 and T4. So T3 is triiodothyronine and T4 is tetraiodothyronine. So it's a more active form. So we'll show the differences between these two hormones T3 and T4. The first difference, which is the more active form of hormone, it is T3. So it is more metabolically more active. If you see the activity wise, if you give activity of T3 as 1, the activity of T4 will be 1/3 of that, 0.3. Okay, so activity or potency of the hormone, we can say the potency of the hormone is, if you give 1 for T3, it will 0.3 for T4. That is more metabolically active form. Now, what about the half-life of T3 and T4? Half-life of T3 is 1 day, half-life of T4 is 1 week. 1 day and 1 week. Okay. Now, what do you think in the thyroid gland is synthesizing thyroid hormones. So from the thyroid hormones, the major hormone which is released in the bloodstream will be T4. And less of T3. And if you take the bloodstream, the total percentage of T4 in the circulation, 100% of T4 in the circulation is from the thyroid gland itself. That is, thyroid, whatever T4 you see in the bloodstream, it is from the thyroid gland. Whereas T3, only 20% of what you see in the bloodstream is coming from the thyroid. So the rest is actually produced from what? The rest is produced from T4. So that is, you have T4 to T3 conversion happening in the periphery. This is with the help of an enzyme known as deiodinase. This is what we have been taught, that deiodinase. Yeah. This is what we have been taught, like peripheral conversion of thyroid hormones. Peripherally, T4 is converted to more active form, that is T3. So that is deiodinase. So if you take the potency wise, more active form is T3, less active form is T4. If you take the half-life, more half-life is for T4. This more half-life is because of plasma protein binding. So if you see the plasma protein binding, the plasma protein bound form is what is a bound form, whereas the free form of the hormone will be more active form. So if you take the percentage of free hormone, T3 0.3%, 0.2 to 0.3% is free form, whereas for T4 only 0.02% is free, around 0.02%, around 99.98% of T4 is in bound form, only around 0.02% is free. whereas for T3 around 0.2 to 0.3% is in the free form. So this is the reason for this prolonged half-life of T4, because most of the T4 is bound to plasma proteins. And what plasma proteins are they bound to? That is thyroid hormone binding proteins in the plasma. We have mainly 3 binding proteins in the plasma. One is thyroxine binding globulin or TBG, second one is albumin, and third one is transthyretin. These are the 3 thyroid hormone binding proteins in the plasma, of which the most important one is TBG, which binds around 70% of the thyroid hormones. 70% of thyroid hormones is bound by thyroxine binding globulin or TBG. Fine. So that is the significance of this. Half-life is prolonged because of increased plasma protein binding. Okay, so the significance of plasma protein binding is that you have actually a pool of thyroid hormones in the bloodstream which can be mobilized to the free form. Only the free form will be active. Only the free form is active. So when you need active hormone, you can mobilize from this bound form. That is the significance. You have a large pool of thyroid hormones in the bloodstream in the bound fraction. Fine. Now, so this is about the differences between T3 and T4. And what about this peripheral conversion? This peripheral conversion is with the help of enzyme known as deiodinase. And basically you have 3 types of deiodinase. They are numbered as D1, D2 and D3. What are the important points I will highlight here? In the bloodstream, the most of the T3 you get in the bloodstream is with the help of D1. So D1 is the main source of T3 in the circulation. T3, the main source is D1, type 1 deiodinase, type 1 deiodinase. And type 1 is the most abundant form also. Whereas D2 form is the main intracellular source of T3, the main intracellular source of T3 is D2. Whereas the function of D3 is actually inactivation of T3 and T4. That means actually if you look at the structure of the thyroid hormones, you have 2 rings, outer ring as well as inner ring. Okay, so if you are removing the iodine from the outer ring, you get an active form of the hormone. Whereas if you remove iodine from the inner ring of the thyroid hormone, you get inactive form of the hormone. That means D3 is actually removing iodine from the inner ring of the thyroid hormone. That is why you get inactive forms of thyroid hormones. Inactive T3 is known as T2. Inactive form of T4 is reverse T3. They actually inactivate this thing. So this D1, the sites where you get D1 is mainly in the kidney and liver, along with some form in the thyroid. Whereas D2 is present in the brain, pituitary, brown fat, also it is present in the skeletal muscle and heart. Whereas D3 is mainly present in the placenta, along with some form in the CNS. And D3, increased expression of D3 will be seen in certain tumors, mainly hemangiomas. See, whenever a child is coming with hypothyroidism, and if the child is having some form of hemangioma, this hemangiomas will express increased form of this D3 or deiodinase type 3, and they will actually inactivate these thyroid hormones, resulting in the production of inactive forms, and these patients will have hypothyroidism. So one cause of hypothyroidism you will see in all the books is what is known as hemangiomas resulting in hypothyroidism, and this hypothyroidism is what is known as consumptive hypothyroidism. Consumptive, because actually these hemangiomas are actually producing the D3 and resulting in thyroid hormones being consumed or converted to the inactive forms. So this is the deiodination step. So this deiodination is responsible for the production of active form of the thyroid hormone, which is T3. In fact, 80% of the T3 in the circulation is coming from deiodination, only 20% from the thyroid gland. So this is a table from Harrison showing the differences between T4 and T3, right? So first is what I mentioned was the metabolic potency of the hormone. If you take 1 as T3, it is 0.34 T4, right? Second one I told you was regarding the fraction from the thyroid. So T4 100% is coming from the thyroid, and for T3 only 20% is coming from the thyroid gland. Regarding the half-life, 7 days or 1 week for T4 and 1 day, actually it is most of the books 1 day. You can also say 1 to 2 days. In most endocrine books you will see it's 1 day. Less than 1 day is actually the half-life of T3. Now, the fraction of the hormones in the unbound form or the free form, it is 0.02% for T4 and 0.3% for T3. This is the reason for this half-life also, right? Rest of the things are not that important for you. So this is these 4 points, 1, 2, 3, 4. These 4 points are important, right? Right. Now just see this deiodination also. This is the inner ring and this is the outer ring. So you have, this is deiodinase 1 and deiodinase 2. It is doing 5' deiodination. This 5' is actually the outer ring. So outer ring deiodination result in active form of the hormone, whereas 5 deiodination, this is the 5 deiodination that is present in the inner ring. So inner ring deiodination result in the production of inactive form of the hormone. So T4 is converted to reverse T3, whereas T3 is converted to T2 by this type 3 deiodinase, right?